Bismillahirrahmanirrahim. So, welcome to this exciting journey through gold standard trabeculectomy procedure. Make your trap safe. And we are glad, honored by presence of Dr. Rashid, an eminent surgeon from UK, a glaucoma surgeon and a phaco champion with us. And we are going through this trap. And we start the webinar, and I'll let you know the agenda of this webinar. And we started with recitation from Holy Quran. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم هل أتى على الإنسان حين من الدهر لم يكن شيئا مذكورا إنا خلقنا الإنسان من نطفة أمشاج نبتليه فجعلناه سميعا بصيرا إنا هديناه السبيل إما شاكرا وإما كفورا إنا أعتدنا للكافرين سلاسل وأغلالا وسعيرا إن الأبرار يشربون من كأس كان مزاجها كافورا عينا يشرب بها عباد الله يفجرونها تفجيرا يوفون بالنذر ويخافون يوما كان شره مستطيرا ويطعمون الطعام على حبه مسكينا ويتيما وأسيرا إنما نطعمكم لوجه الله لا نريد منكم جزاء ولا شكورا إنا نخاف من ربنا يوما عبوسا قمطريरा। ये सूरह दहर की आयतें हैं। इसका दूसरा नाम सूरह इंसान है। The other name of this surah Dahar is the human. Hal ata ala al-insani hinum min ad-dahri lam yakun shay'an mazkura. Has there come upon man a period of time when he was not a thing to be mentioned, worth mentioning. Inna khalaqna al-insana min nutfatin amshajin nabtalihi faja'alnahu sami'an basira. Indeed, we created man from a sperm drop mixture that we may try him, and we made him hearing and seeing. Inna hadaynahu sabila imma shakiran wa imma kafura. Indeed, we guided him to the way, be he grateful or be he ungrateful. So both the options are there. Inna atadna lil kafirina salasila wa aghlalan wa sa'ira. Indeed, we have prepared for the disbelievers chains and shackles and a blaze. Innal abrara yashrabuna min ka'sin kana mizajuha kafura. Indeed, the righteous will drink from a cup of wine whose mixture is of kafur. Aynan yashrabu biha ibadullahi yufajjirunaha tafjira. A spring of which the righteous servants of Allah will drink. They will make it gush forth in force and abundance. It will obey them. They will draw it wherever they like. यूफून बिन नज़री व यखाफून यौमन कान शर्रुहु मुस्ततीरा। इनके बारे में कहते हैं कि हज़रत अली रज़ियल्लाहु अन्हु और हज़रत फातिमा रज़ियल्लाहु अन्हा की तारीफ में अल्लाह रब्बुल इज़्ज़त ने आयत नाज़िल फरमाई, जो उन्होंने 3 दिन तक रोज़ा रखा और तीनों दिन अफ्तार के वक्त एक साइल आ गया और उन्होंने वो जो अफ्तारी थी वो साइल को दे दी और खुद दोबारा इसी तरह से रोज़ा रखा। तो ये उनके लिए अल्लाह रब्बुल इज़्ज़त ने एजाज़ फरमाया कि कुरान पाक में ऐसे किरदार की तारीफ हमेशा के लिए नकल कर दी। यूफून बिन नज़री व यखाफून यौमन काना शर्रुहु मुस्ततीरा। They are those who fulfill their vows and fear a day whose evil will be widespread. وَيُطْعِمُونَ الطَّعَامَ عَلَى حُبِّهِ مِسْكِينًا وَيَتِيمًا وَأَسِيرًا. And they give food in spite of love for it to the needy, the orphan and the captive. إِنَّمَا نُطْعِمُكُمْ لِوَجْهِ اللَّهِ لَا نُرِيدُ مِنْكُمْ جَزَاءً وَلَا شُكُورًا. We feed you only for the continence of Allah. We wish not from you reward or gratitude. ये अल्लाह के बंदे कह रहे हैं. The servants of God say like that. Inna nakhafu min rabbina yawman abusan qamtarira. Indeed, we fear from our Lord a day austere and distressful. So may Allah make us one of those who will be rewarded on the day of the judgment. So with this, we start our webinar, and it's a poetic journey. So Dr. Rashid has to tolerate a little poetry now. अपने हाथों में फैसले होते, कब के हम एक हो चुके होते. अपने हाथों में फैसले होते, कब के हम एक हो चुके होते. कैसे असरार इश्क के खुलते, मुब्तला हम नगर हुए होते. आप ना जाने अंजुमन होते, हम भी ता देर ना रुके होते. हम ना लगते खज़ा रशीदा यूं, आपके संग खिल रहे होते. तेरे बिन वक्त काटते हैं हम, तू जो मिलता तो जी रहे होते. तेरे बिन वक्त काटते हैं हम, तू जो मिलता तो जी रहे होते. मिलते दिखते हैं आसमानो ज़मीं, क्या था जो असल में मिले होते. मजहरी आपका हुआ है काश, आप भी उसके हो गए होते. तो आधा काम तो हो गया, आधा नहीं हुआ. So with this, we come to our webinar and today's meeting, and I introduce you to British Pakistan Ophthalmic Society, BPOS. This webinar is co-sponsored by Virtual Ophthalmology Academy and BPOS. Virtual Ophthalmology Academy is VOPHA, and British Pakistani Ophthalmic Society is BPOS. So this British Pakistani Ophthalmic Society was founded to strengthen collaboration between UK and Pakistani ophthalmologists, and it was founded by Dr. Ijaz Sheikh, who was the founding president and director of operations, and he initiated this society along with Dr. Rashid sitting right in front of you, and Dr. Imran Masood, which is Dr. Rashid mentor of mentors. And all of them are my mentors as well. Key initiatives: academic exchange, fellowships, virtual learning. So these are the objectives of this society, but sky is the limit. I mentioned to you that I am going through this virtual fellowship program of BPOS in Glaucoma. So it's a great learning opportunity they are providing to nationwide Pakistani ophthalmologists. And they support mentorship, research, and outreach for ophthalmic care. And this is just the beginning. Hopefully, by the time you pass your fellowship examinations and join as consultants, BPOS will be extending and offering much more opportunities for Pakistani ophthalmologists to nurture and grow. And this Virtual Ophthalmology Academy is a virtual platform which was founded by myself and my younger brother, who is an engineer and IT genius, Mazhry. So we had this idea, and Alhamdulillah, it's also flourishing. And these are the beauty with these two platforms is that they are purely academic. No politics, nothing else. Just a passion to deliver to Pakistan and to ophthalmic community around the world. And this webinar we are going through will be available on VOPHA YouTube channel. Its recording will be there. And we are using the VOPHA's own dedicated platform of Ring Central for this webinar presentation and recording as well. And VOPHA has so many potentials, inshallah, which will be unfolded to the ophthalmic community in future. And I introduce you to Dr. Rashid Zia. You can move your laptop and focus Dr. Rashid in the picture. He graduated from King Edward Medical College in 1997 and got his FRCS from Edinburgh in 2005. He is a consultant glaucoma specialist in United Kingdom and has got advanced glaucoma fellowship from East Kent Hospital, NHS. He is a lead ophthalmologist with NHS, an independent clinic in Kent, UK. He is a mentor of this advanced virtual glaucoma fellowship, as I already mentioned, BPOS, and award-winning research in cataract surgery safety are his expertise, and complex glaucoma and high-volume cataract surgeries is his passion. And LRBT is also one of his key institutions where he worked in Pakistan. And Dr. Ijaz Sheikh will be joining us, and he is also a proud Pakistani ophthalmologist based in UK. He is consultant ophthalmologist and a retina and oculoplastic surgeon. 40 plus years in cataract, retina and oculoplastic surgery. A great educator and mentor. And he is doing a lot of charitable eye care initiatives for undeserved regions and promotes high standards of global ophthalmic care. Known for patient-centered and personalized care, and he is above all founder of this British Pakistan Ophthalmological Society. So the agenda of, and myself is here. I am the founder of Virtual Ophthalmology Academy and a humble member of Ophthalmological Society of Pakistan, and got my MBBS from Allama Iqbal Medical College, and then FRCS from Edinburgh and FCPS from Pakistan. And currently I am working in WAPDA Teaching Hospital as head of department, and my passion is poetry and ophthalmology. So Mazhry, the poet ophthalmologist, and I have alhamdulillah 30 years of experience in this ophthalmic surgery, and I am a comprehensive general ophthalmologist with special interest in advanced cataract, refractive and glaucoma surgeries. So the webinar agenda is that introduction, which I have already gone through, of the speakers and of the sponsors, and now we are introducing you to the webinar. I have written a poem with the name of Make Your Trab Safe, and the poem is dedicated to BPOS and the BPOS glaucoma mentors, especially Dr. Rashid, Dr. Imran Masood, and another contributor is Dr. Faisal, and all others as well, because it's a mashallah big society, big umbrella, but to mention few names. So followed by that poem, there will be a presentation on this topic from myself, followed by Dr. Rashid Zia's very interesting talk, what not to do in trabeculectomy. That's very interesting. And someone put a question during when we were promoting this website, that the glaucoma surgeons around the world are stuck with trab yet. So it was a very interesting notion, very interesting remark, that why this webinar is necessary. I'll come to that point in my presentation as well, but to suffice to say here is that trabeculectomy is gold standard procedure yet, in spite of all the innovations. And the classical trabeculectomy, which all classical ophthalmologists believe that they know everything about trab, is not true. It's evolving like phaco surgery, and you need to learn and customize it like phaco in your own hands. And that's what the aim of today's webinar is, that how to make this classical concept of trab modernized, refined in a way that it becomes safe and predictable in your hands, and can give the patient the aimed and desired benefits. And Dr. Ijaz Sheikh will be there as a speaker, and he will be talking about endeavors and the ventures of British Pakistani Ophthalmologist Society, BPOS, and its future aspects. So I come to my presentation, and the first part of this is the poem, and it's an interesting thing. While going through this fellowship program, this idea was lurking in my mind. On Eid al-Fitr, this Eid after Ramadan with BPOS mentors and our colleagues. I shared a poem with the name of Eco Magic, and the same time it was kind of going up in my mind that I will write something about Trab as well. And then the fellowship got so interesting and so enchanting and so intriguing and so educating that I decided to pay my dedication and gratitude to be pause with this poem. That is, make your trap safe. And interestingly, as you go through the poem, you will, most of the things Dr. Rashid is going to touch are there in the poem as well. Prepare the stage with wisdom's light, where steady hands must work right. We are setting the surgical tone for the procedure. Prepare the stage with wisdom's light, where steady hands must work right. Before the knife, let drops take rest. A quiet eye will heal the best. First, cleanse the eye of toxic drops. Let steroids calm inflammatory pops. And as I am writing these verses, the WhatsApp message of Dr. Rashid are running on back of my mind, which we had this during this fellowship. Detoxifying the eye is the concept. First, cleanse the eye of toxic drops. Let steroids calm inflammatory pops. Let apraclonidine play its role to still the bleed, to keep control. As Dr. Rashid mentioned, that if you can use adrenaline, but then be prepared for the rebound bleeding. So apraclonidine is safer as compared to adrenaline. Let apraclonidine play its role to still the bleed, to keep control. The traction stitch both firm and true, 2 millimeters from limbal blue. No crushing grip shall mar the white. A sponge's kiss shall hold it right. And this is a still from Dr. Rashid's video. You can use this spear sponge to control the eye movement and try not to tear the conjunctiva. No crushing grip shall mar the white. A sponge's kiss shall hold it right. Treat conjunctiva with due respect, or face a wrath you won't expect. Treat conjunctiva with due respect, or face a wrath you won't expect. This verse is dedicated to Dr. Faisal, who added some beautiful sentence, and I made a verse out of it. Treat conjunctiva with due respect, or face a wrath you won't expect. Let Teen yield, yet free from harm. No rough embrace shall steal her charm. Dissect with patience, slow and wide, where MMC must safely reside. Let on the bed 2K's blade sway, to keep fibroblasts fierce bloom at bay. Use gentle cautery, calm and brief. Leave no bleeding tuft, nor char to grief. The scleral flap, exact and precise, 4x2, no more, no less, suffice. Nicely cut, no more, no less, to grant control and free access. A rectangle carved with patient art guides flow to its posterior part. That's the lesson of this modern trap, that posterior flow is our target. Rectangle carved with patient art guides the flow to its posterior part. Place MMC with watchful gaze, not near the limbus where dangers blaze. The sponge removed with steady hold, lest conjunctival edges touch a fold. Pre-place your sutures, don't delay, for hypotony steals success away. So hypotony is the biggest enemy of trap. So, two visits with hypotony by all international standards is a failure of trap. Pre-place your sutures, don't delay, for hypotony steals success away. The sclerostomy, modest in size, shall channel flow and let it rise. Trim iris with a graceful snip, a tranquil stream, not idle slip. Two sutures now with tension right, not strangle taut, nor loose in flight. Releasable they must remain to guide the tide, yet not constrain. Close conjunctiva with knots that kiss, a watertight bond none should miss. This is also a very big advice for success of trab. Do a watertight closure. Close conjunctiva with knots that kiss, a watertight bond none should miss. Take utmost care as you seal and stitch, leak or hypotony, each a surgeon's glitch. A leak unchecked may spoil the day, so close with care, then watch and pray. शिफा तो फिर अल्लाह के हाथ में ही है ना. A leak unchecked may spoil the day, so close with care, then watch and pray. With steroids, balm and watchful eye, 3 moons must pass before you sigh. Means 3 months. Refinement comes not in a race. Learn from the failures we embrace. For trabs are not born from blades alone, but from the care our hands have known. Touch the eye as a lover's grace, with tender art and soft embrace. फूलों की तरह टच करना. Treat high like flowers, like a beloved's face. With passion, practice, knowledge and skill, make your trab safe by God's will. So thank you for this poem, and I have taken enough time. I may skip my presentation.
Brilliant. Thank you very much. Beautiful.
तो मेरा ख्याल है poem is enough. अब हम आपकी presentation की तरफ चलते हैं. फिर time बचेगा तो I will come to my presentation. That is customize your trabeculectomy to make it more predictable and safer. But first we let our guest speaker.
So thank you very much, Professor Mazhry, for giving me an opportunity to present what not to do in trabeculectomy. I apologize, I was unable to modify the presentation for WAPDA Teaching Hospital because my laptop stopped working. So I'm sharing one of my old presentations and I hope this will suffice. So before I proceed, I would like to share a very small sketch. So you can see a great big panda and a small dragon resting on his head. So these two guys are friends with each other and they are out on a walk and learning pearls of wisdom. So the big panda says to dragon, after looking at a small bee, that try to make time for small things, said big panda. They're often the most important. And this is the crux of the presentation, that we'll be looking at small things, how to improve the outcome of the trabeculectomy, and how to ensure that we offer safe trabeculectomy. Another thing that I must emphasize before the presentation is that the time-tested idiom of practice makes perfect is an absolutely incorrect sentence. Practice doesn't make you perfect. It only cements your bad habits. You will never get better without rectifying your errors. So if you are practicing a bad habit, you're only cementing it. You're not becoming perfect. And that's Bruce Lee. And he once said that I fear not the man who has practiced 10,000 different kicks once, but I fear the man who has practiced one kick 10,000 times. So we must, as clinicians, as healers, we must practice the right steps to become perfect rather than picking up bad habits and not learning and not executing the right thing. So some common remarks that I come across in the last 4 to 5 years of advanced glaucoma fellowship at BPOS is that mostly when I'm discussing with even very senior consultants and professors in Pakistan, they say the trab is a simple 20 minutes procedure. So if someone gives a similar remark on an international arena, others will have only one notion, that this person does not know how to perform trab or to assess a person who's performing trab. A properly done trab takes almost an hour, 45 minutes to 1 hour. So these are all unwanted outcomes of trabeculectomy. If you see a cystic bleb, your pressures may be very well controlled with a cystic bleb, but that indicates the surgical technique was faulty. If it's a hypotony, again, what to blame is the surgical technique. An insisted vascularized bleb, faulty technique. An avascular bleb, faulty surgical technique. Leak, faulty surgical technique. Tenon cyst, well, in majority of cases, is a faulty technique, but sometimes it can still happen. So this is the aim of the surgical procedure, that we want a very diffuse, slightly elevated, normally vascularized bleb with predictable outcomes. And to have a predictable outcome, you have to play with all of these various chemical factors like growth factors, many different kinds of cytokines. You need to understand receptors, various enzymes, pleiotropic genes, which are whatnot. There are thousands of different things that play the outcome and their role in the outcome of the safe and predictable surgery. So this is a figure from Professor Peng Kaur, who introduced the concept of safe trabeculectomy from Moorfield. This is a paper that every trab surgeon must read. I believe not reading this paper is negligence. It's such an important paper. So this diagram, you can see there are scales with you have positives, you have negatives. So what you can see here are there are many different kinds of reactions when you do a glaucoma surgery. Initially, clotting happens, then you have vascular responses, you have inflammation, you have fibroplasia, granulation tissue, and in the end, remodeling of the scar and the wound. So you can see at each stage, there are many different things which will promote a certain like there are few things which will promote clotting, there are few things which will promote vascular response, there are few things which will promote inflammation, and then each step, each phase also has antagonists which will also dampen these things. So for example, in clotting you have fibrin which will promote clotting, but at the same time heparin will prevent clotting. Similarly, after surgery, if your eye is very red, very vascular, that's dried by VEGFs and platelet-derived growth factors. But if you've done good hemostasis, then the vascular response may be less. And similarly, the most important thing is the inflammation. And in inflammation, you might see this word TGF-beta, tumor growth factor beta. It's actually present everywhere. It's present in inflammation, it's present in fibroplasia, it's present in remodeling. This is one of the most important chemicals which determines and is responsible for the outcome of the trabeculectomy. This is what we do not want. This is what we want to control. And the whole concept is to address the factors to promote, is to control the factors which will lead to enhanced scarring. We want the wound to heal, but we do not want the wound to scar. So in that quest to improve the trabeculectomy practices in Pakistan, we did a national survey about 3 or 4 years ago, and these are the answers which are from the experienced consultants and professors only. So these are the answers. We omitted the responses from trainees. So these are the answers by people who have a minimum of 5 to 10 years of post-FCPS experience, and those who have high, and those who are experienced glaucoma surgeons. So in this, we asked the first question, that when do you offer TRAB in your patients? And very surprisingly, we found that majority of surgeons, almost 90% of surgeons, they offer trabeculectomy very late in the disease process, which is what we like to address today. Because if it's very late, that means you have exposed the patient to the toxic effects of drugs and the preservatives in the drugs. And you know the benzyl alkonium chloride back in the eye drops, it's related to higher level of inflammation. It leads to higher fibrosis. It causes more fibroblast proliferation. It causes more collagen synthesis, causes more scar. So if you have exposed the conjunctiva to this kind of drug, it will lead to scarring, and scarring leads to failure of trabeculectomy. So we do not want eye to get toxic. And this is an example. So over here you see virgin conjunctiva, and in that you can see the amount of goblet cells. How little are they? On this side you can actually see just 1 week of travoprost or travatan, and you can see the expression of goblet cells. Compare this expression as compared to these occasional goblet cell. So this is a very fine example on histological basis that how toxic you make your conjunctiva, and then we expect good results, which is, I think, is unfair. So this is another very good example. So white disc is the sclera disc. You add fibroblast to it, and in day 4, you can see the sclera disc will constrict. It becomes smaller, contract due to scarring. But if you add an inflammatory cell to the same disc with the same number of fibroblasts, you can see the scleral disc contracts far more. So here you have the bleb and the fibroblast, and you can see the fibroblast actually reels in the collagen, like on Basant when people do kite flying. Similarly, the fibroblast, the activated fibroblast, it reels in the collagen, and you can see it makes the bleb very small. So this is what we want to avoid. And secondarily, there's another, from the questionnaire, we realized that people and surgeons, experienced surgeons in Pakistan, are also quite fond of phacotrab. Phacotrab is not a primary procedure. Phacotrab is a recipe of failure. So this is a very nice example. So the green graph is that of trabeculectomy, and the red is that of phaco. So once we do either phaco or trabeculectomy, you can see the inflammation rises exponentially within the first 1 month, and then they come back to the baseline. In trabeculectomy, the intraocular inflammation, or the aqueous flare, this is a flare that you cannot see on slit lamp. This is only visible on laser interferometry. And you will see that it comes back to the normal baseline within a month after trab. But what happens in phaco? You won't see this flare on slit lamp, but the flare is still there and doesn't come back to even normal level after a year. It becomes reasonable at around 6 months, but it may still never come back to baseline level even after a year. So if there is a persistent microscopic inflammation going on after phaco, you do trab. Trab is more likely to fail because you are operating on an inflamed eye. That's why phacotrab is not a primary procedure, but there are conditions when it can be done. So this is another example. So this eye has pressure of 8, vision of 6.6 post-op trab, and it's post-op 3 months. So here I would like to add or edit Professor Mazhry Saab's poem that it's just not, usually it's 3 months, three moons, but it can be way more than 3 moons. And nowadays, in this era of extensive pollution, which is very, very important, especially the nanoparticles in pollution, which are very high in Delhi, Lahore, Karachi, even in London, and exposure to the toxins in the processed foods like burgers, McDonald's, etc. These are all things which lead to various diseases. I wish I could show you how the diet and the pollution changes the health. It's amazing. It's drastic. So nowadays you may not find that the trab has settled down in 3 months. It may take significantly longer, especially if you have operated in an eye which has been exposed to the toxins of drops and preservatives for years and years. So this is the same eye. I could have stopped if I see pressures of 8, vision 6.6 after 3 months, patient very happy. I could have stopped steroids, but I continued the steroids. And after 6 months, you can see the same conjunctiva. You can see the difference in vascularization. This is why it's very important to have a slit lamp photography record of comparing the blood vascularity, because otherwise you may not find. Even in this eye, I find this blood vessel to be slightly more inflamed. Hence, I'm still reluctant to stop steroids. I may still keep this person on once a day at Forte or dexamethasone for even longer. And nowadays I've found that it's very difficult for me to stop, even in UK, the post-op steroids for about 9 months to 12 months. Most of the post-trab patients, they stay on steroids for a very long time.
So I will modify that word.
It's a many moons. Rather than 3 moons, many moons.
May take many moons.
Okay, so the recommendation is avoid poisoning of conjunctiva and tenon with excessive topical treatment, so operate early. But you cannot operate early with a good vision unless you are proficient in providing safe trabeculectomy. And that's the main reason why there is a cultural shift in Pakistan as compared to UK, where we operate in UK, we do trab early. Here we trab late because surgeons are afraid of trab complications in Pakistan. Over there, our complication rate is very low. And do not stop topical steroids unless the bleb is of normal vascularity. If you are reducing the steroids and the bleb starts to become inflamed again, then regardless of the pressure, you increase the steroids. You can give straight away a subconscious dexamethasone injection, and you can give it as many times as you want. But do not let the bleb stay red. And this TAGS trial is a primary trabeculectomy for advanced glaucoma. If a person comes to you with advanced glaucoma, do not make it toxic. Control pressures with acetazolamide, do trab on the next list. Okay. So then there was, in the survey we found that many surgeons, senior surgeons, still use superior rectus bridal suture. And using a superior rectus bridal suture is not really recommended in trabeculectomy because it causes more inflammation and it has increased trab failure. So over here you can see that majority of senior surgeons in Pakistan, about 73% of us, and they still use superior rectus as a bridal suture, which is a practice that must change. So there was a CAT-152 antibody trial. That was the antibody to tumor TGF-beta, which I was sharing with you, anti-TGF-beta trial. So in that trial, the surgeons who were using superior rectus, they had higher trab failure. Anyway, this trial was abandoned prematurely due to the higher failure rate. So always use a corneal traction suture. So this is the recommendation, to abstain from superior rectus traction suture. Now, oh, what did I do? Okay, so this is the recommendation 5 is to avoid holding conjunctiva. Have atraumatic conjunctival holding. Try to hold tenons rather than holding the conjunctiva. So how do I play this? How do I? Okay, so it may not play because okay. So I'm sorry I can't play the video here. Also, avoid limited subtenon dissection. That I will show you a video. So
when you end, I have these clips.
Okay, you can.
Or chat.
All right,
So
you can.
I'll show
Okay.
I'll show and you will explain.
Okay.
All these clips are there.
Brilliant. So this was a question that we're just talking about fornix-based trab. We're not talking about limbal-based trab, the normal fornix-based trab that we do. When we do conjunctival and subtenon dissection, it should be, how do you perform it? So you will find still majority of very experienced surgeons, post-op, postgraduate senior surgeons, they just do a very small, limited trab dissection, which is not correct. I'll let you know why. So we actually need, if you make a very small dissection, you're going to get this, a small, limited, encystic, high-pressure bleb, which will leak later on, like these. These are, when you see such blebs, that means the dissection was inadequate. And when the blebs did come under pressure, conjunctiva is not designed to hold aqueous under pressure. It will break down and it will start leaking. So there's a very famous saying that it's not the leak that leads to hypotony, it's the hypotony that leads to leak. We will discuss that in a later. So this is Professor Pencor. So what he's showing over here is that if you do not do dissection, that when the water comes out, it has to go through a lot of septae. So if you dissect conjunctiva, you would appreciate there are a lot of septae. So those septae, they prevent the aqueous to flow out and backward. We want posterior flow. So if you do not do posterior dissection, the flow would not be directed posteriorly. It will be localized anteriorly, leading to anterior cystic large blebs. And here you can see after dissection, there is no resistance to the flow of the aqueous. Similarly, so this was the experiment to mention the same concept, that for example, if you have a device and you put that device intracamerally, you go through the anterior chamber, go through the angle and put that device under the conjunctiva through the angle, and it will start draining the aqueous under the conjunctiva and under the tenon. But the same device, if you put it into the anterior chamber after dissecting the subtenons, will work better, because in the earlier case, when you have put the device under conjunctiva through AC, will drain into the subtenon space, but it will be limited by septa because you haven't dissected. But if you have opened up the subtenon space and then put the same device into the AC, it will now drain into the subconjunctival place, which has been dissected with no resistance. So it will have lower pressure. Okay, so that was done. So wide dissection is the point. The next is avoid mitomycin C touching the anterior conjunctiva. So this is very important. And also, please understand what kind of sponges that you're using. It's very common to have cellulose sponges, but at the same time, it's very common to have PVA sponges. A cellulose sponge may degrade in the subtenon space when you apply, and those retained cellular matters can be a source of inflammation and hence later blood failure. So use PVA sponges to use. So this is the video that I use from, I just borrowed from Google. It's about an Indian surgeon. So you can see he's placing the mitomycin C. First, he's placing it very anteriorly. Then his mitomycin sponges are actually touching the anterior conjunctiva. And then on top of that, what he does, so you can see all of his sponges are touching the anterior conjunctiva. Then he pulls the conjunctiva back to the limbus and ensures that the mitomycin sponges are then fully in touch with the conjunctiva. Such a bleb, so that will lead to avascular bleb. Can you see this avascular bleb? So first the dissection was small, that will lead to anterior, and then once exposed to anterior conjunctiva, the bleb is likely to become avascular. And then
it will heal.
It will leak, it will heal. There are many.
Yeah.
So you do not want mitomycin C to touch the anterior part of the conjunctiva. This is where you need to place the mitomycin sponges, not in this area. So this is the example by Imran Masood. He's operating here. So you can see he's first holding the tenon, not the conjunctiva. Then he makes a pocket and he puts it very posteriorly. So his sponges are right there at the bottom. Okay, so, and he keeps the clamp high. He's not clamping the conjunctiva, he's just holding the conjunctiva. And see, once he removes the sponges, he does not touch the anterior conjunctiva. So he ensured that the mitomycin C exposure is to the posterior. And nowadays, even in Caucasian eyes, we are using 0.5 or 0.05% or 0.5 milligram per deciliter mitomycin C concentration rather than 0.2 or 0.4. So we are using higher and higher concentrations of mitomycin C, and we're not afraid of using it because we're using it appropriately in a posterior conjunctival subtenon space. So the other thing is, if you look at trabeculectomy practice in Pakistan, what we found that people are obsessed with making different sizes and shapes of the scleral flaps without any understanding of the engineering concepts, without understanding of the physics of the flow of aqueous and drainage. So let's talk about a triangular flap, which is the most commonly done flap. So if you make a triangular flap, water will find its way to the shortest resistance. So if you have water in any reservoir, it will flow out through the area which has least amount of resistance. That's the nature of the physics. So if you make a triangular flap and you have a central sclerostomy over there from aqueous coming out, the distance from this area to the tip of the triangular flap is way more than the sides. So the water is going to go out from the sides. If water goes out from the sides, it's going to make an anterior bleb, which we do not want. So a triangular flap technically is an inferior way of surgery, which is promoting an interior bleb, which we do not want. We actually want a rectangular flap. What a rectangle does is that the distance from here to here is shorter as compared to distance from here to the sides. So the water is likely to go to the posterior side.
That's the posterior flow.
That's the posterior flow. If in your surgery you see leakage from here, you need to put a suture there. You need to put a suture there so that it doesn't leak on the sides. You only want it posteriorly. And also, a triangular flap will only work if your sclerostomy is right in the middle. If you have a large sclerostomy of making this big area, the concept of any kind of a scleral flap goes down the drain, because we want a very small sclerostomy, only 0.5 to 1 millimeter maximum, and right bang in the center of your rectangular flap for the water to flow posteriorly. So please do not make large asymmetrical sclerostomies. So so this is, I'll show, I had a video to show it better. So here it's slightly asymmetrical, but still it will ensure that the flow of water would be from here. But in this case, as this distance is smaller, so the water can also flow out from here. So I have to ensure that the lateral side is blocked. Okay. And use Kelly punch or core punch are widely available in Pakistan. So it's worth investing in this instrument rather than to make a block of a sclera conjunctiva block with the blade. That is not, because that, no matter how good a surgeon you are, you cannot make a central block excision of 1.5 millimeter. It's just not possible. You may be a very good surgeon, you may be able to do it once, but you may not be able to replicate in the next procedure. So why to do an unpredictable procedure? So, and then once you put the sutures in, sutures are there to offer resistance. And as healing happens, as the resistance increases, you want the sutures to be released so that more aqueous can flow out, so that you can control the pressures. So any suture which is fixed, there's no harm in doing a fixed suture, but then you should be able to laser it. If you cannot laser it, there's no sense to put a fixed suture in trab, unless it's really leaking and you don't want. That's a different matter. So you want a suture that can be adjusted or released or lasered. If you're not doing this, you are not doing trabeculectomy. That's old school. That's trabeculectomy took 65 to 70 years to evolve. It's a lot of science in it, a lot of physics in it. So let's not stay in last century. Using fixed suture was last century from our forefathers. It has moved on. You must use either adjustable, releasable, or if you've used laser somehow because you're not trained to do releasable or adjusted, then you should have a laser in your department. Okay, so this is whenever you create a flap, you do a sclerostomy and you put sutures in. All of these things, they are trying to attain the same object. They are trying to attain an optimal flow, not too much, not too little. They are trying to attain posterior flow, not the interior flow, and they are trying to attain predictable flow so that you do not have very low pressures or very high pressures. So this is the way to do releasable suture. So you can pass the 10-0 nylon like this through the sclera and come out through the cornea. You can have a corneal slit so that it comes out through the corneal slit. In that case, if you do not remove a suture, it will stay buried under the slit. So this was me in the early stages when I did not like making a corneal slit, but now I always make a corneal slit. If you make a corneal slit, the suture will be well buried underneath. If you do not need to remove it, it stays like that for the rest of the life. Otherwise, on a slit lamp, you can pick it up with a needle. Okay, and then you pass it back through, come out through the blab, and then you take a wide, it's a wide bite. So the bite needs to be bigger because a smaller bite will lead to less resistance. So you need equal side on both sides. So this is how it happens. You do the same thing on the other side, and then you take four throws, just 4 throws, and then you tie just like a shoelace. Okay. So you can see
this suture is
10-0 nylon.
releasable.
This is releasable.
Is it adjustable as well?
The same. The definition is this is releasable, but because even if you do massage to it, it's going to get loose. So we can say it's adjustable too. But this is basically a releasable suture. If you do not want to do massage, you can from on top of the conjunctiva, you can take a forceps and move it like this. It'll become loose. So it's
take hold of that loop. Yeah. It gives you a little.
It becomes just like a shoelace. Yes. If you move it like that, it'll become slightly loose. So it's adjustable too. Adjustable means making it loose, not making it tight again. So the concept is, if you are in UK, from where all this research came, if you are in the south of the UK, from Moorfield, they when they put sutures in, they want zero flow. So which means the next day the pressure would be around 20s, high, even maybe as high as 25 to 30 sometimes. So the first post-op day, they expect higher pressures. Then they do massage on the table. The pressure drops to under 10. They will let the patient sit outside, call back after half an hour or so, and see what's happening to the pressure. If pressure is rising again, so they might do massage again. Massage is good enough to adjust the sutures. Okay. If pressure starts to rise again, that means they have to take a forceps and just move the. So do not remove the suture on the first day; it will become very soft. Okay. So, the first day, expect pressures to be higher, and then you drop it down with a massage or slight adjustment. That is the modern way.
We have to pass 2 weeks.
Yeah. So we have. Yeah, that is again a very good question. So this is the video which shows the strength of the releasable sutures. Again, I've included a full video so that people can learn. So this is one of my early mistakes where I wasn't concentrating well. So what I've done is I've entered the AC already. I've made it a sclerostomy already. That's why I have to put air bubble in, which is not a good practice because my eye is soft. I should have put an AC maintainer in, because even during the surgery, a soft eye is a risk, especially in myopic eyes, where you can, or people on blood thinners, they can have hypotony can lead to choroidal effusion, and choroidal effusion can lead to stretching of the veins passing through the suprachoroidal space. That can leads to choroidal hemorrhage. Choroidal hemorrhage means invariably you have lost vision. If you know that is what we don't want. So it's exactly the same concept. So you're passing that.
But this realization is very important, which you are already stressing, that we have to take care and prevent hypotony intraoperatively as well as postoperatively.
Yeah. So you see, now what you do is you just take 4 throws. Some people do 3, but 4 is better, safer. There is no bravery in making 3 and saying, oh, I did 3. Just let's be safe. Okay, so you tighten it. So once tightened, you take a spear and check the posterior flow. What I do nowadays is that I do not like zero flow. I like to see
Oozing.
A little bit of oozing. So oozing means the water is not coming onto the sclera. Oozing means that after 5-10 seconds, the wound, this wound is just filled up with, is just getting wet. Okay, so in 24 hours, you have 2.4 micron liters of aqueous producing, and you allow a full drop to come out suddenly, you're going to have hypotony. You need very, very low amounts of aqueous to come out to have pressures under 10. So just wetting of the wound is enough to get you a pressure of 10 or less. So so that's the strength of the sutures. So it depends where you are. I like to see wetting of the wound. Other surgeons, some surgeons may have zero flow, but I think wetting of the wound is more important, is better. And then avoid even the tiniest of leaks. So if your leak is happening, it's almost likely that you are going to have a failed trab later on. So leak is your enemy. You do not want leaking. So this is again Imran Masood. So over here, what he's showing is that he's going to put one wing suture here, one wing suture over there, and then he will do mattress sutures in the middle. Okay, so this, you can see he has these releasable sutures. He has made corneal slits, and he has passed the sutures through the corneal slits. Now, if he wants to remove this releasable suture on the slit lamp, he's just going to take a needle and pluck it out, and then use a forceps and just pull it out. That's very simple. Less than 10 seconds, your suture removed. And so let's see how he closes. So reverse mounted needle, he takes a small superficial bite through the cornea. He comes back, takes the conjunctiva and tenon, and then he passes through the conjunctiva.
It's a kind of modified purse string.
Purse string. And see, you want to see this buckled up area. This area will buckle up. This is what you want to see. And this knot will be buried underneath this buckled up space. So this suture would not be disturbing. Similarly again, so what he's trying to see is how much of the conjunctiva he's going to pull. Again, he's taking a superficial corneal bite, and then he's coming back again. So he goes from inside out, and then from outside to back in at the place where he wants conjunctiva to attach. Can you see? So in this case, this is an African patient who has been toxic, so there is no conjunctiva. So you can see now like this, it's a bunched up tissue on both sides. Now what he's doing is passing, trying to pass a buried mattress suture. He's first taking a corneal bite, then he will come out, take the tenon and conjunctiva. It's very important to stitch the suture tenon back, and then go back in, and then he will. So when he ties knots after passing all those matrices, but I like to tie the knot as I go. So this is your personal preference, but the main point is that you have to ensure that your wound is not leaking. And what he's doing is actually doing overlapping matrices. So his second mattress suture is actually overlapping the first mattress. This is how. Okay, so thank you very much for your patience. I've just touched the very basics of trabeculectomy. I have not touched the entire topic, which can take a whole week to study. We're still doing conjunctiva for the last 2 weeks in the fellowship, and we haven't even, we're in the middle of it. We haven't
and we are not able to cover any topic in full.
Yeah.
Generally, we just
it's a 6-month fellowship.
Move on because the process has to go on.
Yes, so
it's very wise, as Dr. Rashid mentioned during the fellowship. A lifetime is not enough to learn trabeculectomy.
Lifetime is not enough. And trab is still the gold standard procedure. I do pressure flows. I do many MIGS. I do lots of other, we call it MIBS, minimally invasive bleb surgeries. However, the trab stays the gold standard. And it will stay as a gold standard. There is likelihood that in the first world countries where pressure flow is available, in many cases, not all, in many cases, it will replace trab. This seems to be happening because pressure flow has almost equally good results, maybe slightly higher than trab, but still we attain pressures at which glaucoma is non-progressive in nature.
But this pressure flow uses subinjectable space.
So yeah,
so it's not in MIGS.
It's not in MIGS. It's MIBS.
MIBS, because it actually combines the beauty of trab
and
the Martin.
Absolutely. Or even in those bleb surgeries, the concept of the conjunctival and subtenon space is the same as in trab. You have to do wider dissection. You have to do posterior dissection,
and it bypasses.
The
stent definition of MIGS is that it will not bypass. It will rather use the natural channels. It will not bypass them. The trab and the preserved flow, they bypass the natural passages that the trabecular network and Schlemm's canal. If they are bypassed, then it's penetrating procedure. And if it's not bypassed, and there is some stent which just open the Schlemm's canal, or which just communicates the anterior chamber with Schlemm's canal, something like that, then it's a mixed procedure.
It's a mixed procedure. And MIGS can only attain a physiological pressure. We do not promise patients that we are going to do MIGS to offer you very low pressures, because physiologically it cannot attain it. So it will only attain if it's successful. So in overwhelming majority of MIGS procedure, we have to add eye drops to control pressure. So whereas in trab and pressure flow, you can attain pressures of 10-ish without any eye drops.
We have few questions which we will take after.
Okay, thank you.
Dr. Ijaz Sheikh. I welcome Dr. Ijaz Sheikh on the stage, and he is going to brief us about BPOS, and he is the founder and the operating officer of British Pakistani Ophthalmic Society. And the introduction I have already given. He is a passionate international educator, and it's an honor to welcome him on screen and to have him here with us to brief us about the BPOS activities and its future direction. So we welcome Dr. Ijaz Sheikh, and an old colleague and a friend, and we are proud that such excellent ophthalmologists are there to represent Pakistan, and they take care of their Pakistani young ophthalmologists as well. So welcome, Dr. Ijaz Sheikh. Please proceed.
Assalamu alaikum. Thank you for your kind words, Professor Mazhry sir. I'm fascinated by your poems. They're so relevant. So I think you had already elaborated what needs to be done in safe trabeculectomy. So I hope your trainees and all the residents who are in the forum, they can learn from it. So I made a late entry into this program because I felt I have been lacking my presence in Pakistan of late, maybe due to some personal reasons, or maybe we were very busy running this BPOS online adult glaucoma fellowship program. And credit goes to my colleagues, especially Rashid, to have such energy. So you have been part of that fellowship, and you understand that it is non-stop for 6 months, 24/7, unbelievable. So we hope we have developed a team who can take over and carry on with the legacy. Likewise, I have done the same. I just pulled myself back so that new team members can come with new ideas and develop how we're going to run this whole collaboration, because our heart is in Pakistan. Okay? Or what we are looking for is to develop minds. The surgical skill, they're wonderful in Pakistan. People are doing it day in and day out. Like if I do one surgery in half an hour, people can do 3 in half an hour. So that is a different story. But I was trained at my hospital, Lahore, and our Professor Jaliludollah Sahab, he would say, always say, if you have learned to put a wrong suture, you will always do the wrong thing. So as Rashid said earlier, it has to be technique. It's not the number, what you're doing. And this is the whole concept, how we are going to do the things properly and learn. And here comes the saying, okay, like say, fail. I always win. I never fail because I learn from my failures. So that is a key message for all the people around. Keep learning, keep making sure you define the techniques. Like you put the suture first time, next time you'll be better off doing the things properly. So there are a lot of things to do, but keep it simple. Keep seeking knowledge. And if you have at the back of your mind, patient is my priority. Because unfortunately, it has gone very money-driven society everywhere. Not in Pakistan, America, UK, wherever you look at, what I'm getting out of it. But what you're getting is blessing from God. अल्लाह की मेहरबानी नहीं होगी तो आप आगे नहीं जा सकते. तो यही हमारा सारा प्रोग्राम का मकसद था कि if we are starting something which can benefit the people. So it is like 6 years. We started this program during COVID. 3 fellows, and they were very high senior level glaucoma surgeons, and they realized how much they need to learn. And we had given them a task to train further. Each one of you should be training at least 3 postgraduate students to learn how the thing should be done. And Alhamdulillah, the whole scenario of glaucoma management, I'm not talking about the surgery, glaucoma management, how you deal with the patient, how you respect the eye, like how we treat the corneal surface, how we are detoxifying the things, that is the crux. So on that note, I will say, I saw Professor P.T. Kaur in 1990. I had just gone to UK to do my final FRCS exam. I was doing a course at Moorfields Eye Hospital, and I listened to him. I said, oh my God, what he's talking about. He was just a senior registrar, going to be a consultant. And within a few years, he was a professor, and now he's something great. He has done a lot to ophthalmology, and he's always willing to teach. He's giving the ideas to everybody, how the things are working. So the next thing I'm coming to is we had initiated a program called Institute of Ophthalmic Research in Pakistan. Rashid was very keen to do it. We had a lot of webinars and sessions in 2000 and 20. It was just before the COVID set in. We had meetings in Lahore, multiple meetings in Lahore. We went to Multan. We've been going to other places. So it was a wonderful experience. And then COVID slowed down the things. But that concept is still there. And BPOS had initiated a program called PODA. Okay, छोटा सा पौधा लगाओ, बढ़ के दरख्त बन जाएगा. So it was Pakistan Ophthalmic database audit. So we will encourage each one of you to analyze all you're doing, everything you're doing. Because people say, okay, we are lacking in presentations, publications, we don't know how to do it. But people are learning. Our aim was to initiate the concept of audit. I am very keen on that. I have done a lot of talks on that, and I would appreciate if you can get tools which BPOS has given for free. Put all your data, like for glaucoma surgery, you start putting there, what is the outcome, how are we going to proceed, what needs to be done, and we learn from them. So similarly, if you can do the survey, because survey are a very good tool, they're part of research. So from survey, we can do presentations, we can do publications, and we've been doing that. So each one of you can be a writer, you can have publication, because that is the norm. यही currency है जो दुनिया में चलती है कि आपने publications कितनी की हैं, आपने दुनिया को बताया क्या कि मैं क्या कर रहा हूँ. एक मशहूर प्रोफेसर थे लाहौर में, मजहरी साहब के प्रिंसिपल साहब, ये कहते हैं एक हाथ से काम करो, एक हाथ से ढोल बजाओ. Do the work, you can't stop working, but make sure you tell the people what you've been doing. So this is lacking. So it's important. You have such a great platform now. People are enthusiastic. I'm amazed that people who are very, very senior have so much to do in their life, but still joining the glaucoma fellowship, because it's this word of mouth. People say, okay, can we get it? We get so many applications, and we have to shortlist and book it for the next few years. So I hope you who are in training or who are junior consultants, they should be looking at how we can contribute to our own knowledge and pass it over to our patients. So that is the purpose of me to do that. So anybody amongst you, if they want to do audits, survey, or publication, they can stay in touch with us. Mazhry Saab has made his own platform, VOPHA. I think this is very interesting. And I remember when I was in medical school, I graduated in 85, like my two elder brothers were engineers, and they were using these sliders to use the computer work and things like that. I had seen them. I said, I want to learn computer. Oh, you are a doctor, why you need it? And I thought, my God, if I had learned at that time, I would have been miles ahead of everybody. But still, I'm learning. My passion is about artificial intelligence. We have done presentation last time I was in Lahore 2 years ago. We had a full session on that. And then we did some paperwork and some classes and training at Habibai Hospital with Professor Ijaz and others. So people are there to support. So what you need to do is just keep thinking what I can do. Even any small thing, it can be presented. And this is what the people are doing around us. We have such a big database. If we utilize it, we'll be far ahead. So inshallah, I hope my message is respect yourself, respect your patients, keep learning, and you will get to where we want the whole nation to go to, inshallah.
So, Dr. Ijaz,
Thank
if
you.
BPOS can find some enthusiasts like Rashid Zia and Imran Masood in other fields like medical retina and refractive surgery, it will be great to initiate those fellowships as well.
You know, you are also part of Medical Retina Association of Pakistan, MRAP. They're doing a very good job. Thing is, it is something which is more of diagnostic, okay, and it is easier to learn that way. But if you look at the discussions which are happening in there, we have very, very senior ophthalmologists. My class fellow Shazad Shafqat is there, and also Aftab Sakaf, Raja Safda. They give very precise input. So we're working on that. We had a collaboration with the MRAP last year in EU Retina, Barcelona, but unfortunately, people could not get the visas for Pakistan. Only few people who had their British passport or some other passport, they could come. It's becoming difficult. So that is at the back of our mind to look at that. But that team is already well established, MRAP. For glaucoma, it was very rudimentary. And luckily, we found the people. But the team is there. And we hope we can have more collaboration in that front. There has been a lot of talk about it. And it has to be a mutual program. I hope I'll just convey through this message if Professor Tariq Aziz and Sheikh and others who are part of it, they can come up with more ideas, because our team is limited. Like, we have about 250 members. Still is quite a big number. We're considering what are the roles. Some are very junior. Some have just retired, but still they're keen to do the thing. So it is very much possible. We'll take it on board if we can get it started in other areas as well. So, but we can't find people like Rashid or Imran who are there 24/7. I mean, he's the one who kept me dragging. Okay, you need to do that. You need to do that. Please do it overnight. I came for a marriage in, I think it's 2020.
That's why I stressed on the point. We have to find some enthusiasts who make it their object of life to spread the knowledge. So now we have 2 questions from the participants. And if you are you finished, or there is some more point you want to make?
No, I think that's a simple message first. If you
so we move on to Q&A.
You are doing in your sphere of work, just make audit. You have facilities. We can facilitate that, teach that, and I'm keen to deliver lectures on that, because this is how we can go about. But that is the key. Do audit. Check everything you are doing. So I can't hear.
We move to Q&A now.
Okay.
In the chat box, there are few messages from the participants asking something. Like I'll show on the screen, and let
please.
Dr. Rashid to comment on it. Please, Mike, mute.
Okay, so thank you for your message, Laiba. Asif, what is the recommended technique for massage? Well, massage can be done in many different ways. I believe you may have to get familiar and experience with your own technique. So it can be done with or without a gonio lens. So if you want to do with a gonio lens, you need to have the indentation going the smaller diameter than the cornea. Sometimes the amount of pressure you need to do massage can be very little, and sometimes it could be very significant enough to push right back into the orbit. So it all depends on how tight sutures you have placed and what kind of healing is happening, and how fast the healing is happening. But in most cases, very slight pressure with indentation on your lens is sufficient. If you do not have indentation on your lens, then you can they see?
Yes.
You can ask the patient to look up, and then from the place your index finger on the eyelid, and through your eyelid, you can press the sclera gently. First, always try a gentle massage. Recheck the pressures. If that has brought the pressures down, it's fine. If it has not, then you have to apply more pressure. And like this, you can titrate pressure, and sometimes it can be significant. Another way of doing it is to ask the patient to look down, and then you can take your forceps or your sponge or a spear, and you can place it just posterior to the edge of the scleral flap and press it down there. And that will allow the water to certainly flow out. So there are many different ways of doing it. You can excel in any way, just get experienced and comfortable with any way. But you must be prepared to understand one thing, that massage could be very gentle or it could be quite significant. So, and it varies from patient to patient. There's no fixed rule. You can do it with a lens, you can do it with a finger, and you can do it with a spear.
Let me add a little point here that going through Imran Masood's video clips, there was a very interesting maneuver he did to check the patency. After assuring, I will show you maybe a little later. It was here in Rashid's presentation as well. After assuring that the visible suture is tight and the field is absolutely clear, he just pressed the posterior leg and there was a gush. That gives you very good confidence that your fistula is working. And once Dr. Rashid said that you can press it on the slit lamp as well. And the same maneuver Dr. Imran Masood did in the end as well. After closing the conjunctival peritomy and checking the fluorescent dye and making sure that there is no leakage, he again pressed with the micro sponge the posterior lip of the sclerostomy. And again, there was a gush of fluid and the bleb was formed. So that's a very interesting maneuver. I will try to show you from his clips. And it can help, as Dr. Rashid indicated, in the massage as well. Genoman, any other question?
So there was
another question as well. Yeah.
Broad
section with posterior sponges versus primary valve implantation.
So, this is Rao Arif, same Rao Arif that I worked with. Rao, Ophthalmic. I think you're the same person. So Rao is very, very inquisitive surgeon. I didn't understand this question, but primary glaucoma drainage device, which you mean by valve implantation, is also a very valid option in many different cases, especially in cases where you are accepting lesser number of follow-ups or lesser compliance, because TRAB is a technique which demands respect both by the patient and by the surgeon. If surgeon is not well trained, or if patient is not going to adhere with the post-op management, the TRAB is likely to fail. Adherence means that the patient is compliant with the treatment and persistent with the treatment. Compliance is, we have given him to use every 2 hours, he's using it every 2 hours. And persistence is that he's buying it every month to continue using it every 2 hours. So if a patient cannot adhere to the post-op treatment, the TRAB is likely to fail. If a patient is unable to keep follow-up appointments, the TRAB is likely to fail. So in such cases, you can consider putting a valve in, because even the valve is likely to fail too, but it is less forgiving. So valve procedures are no longer an option. Like glaucoma valve is still a very good valve, works really well, but the world is moving towards valveless, like clear path. Clear path is still a very, very big valve. Paul will comment.
Quite big dissection is involved,
Yeah,
and it's
it's
quite mutilating for the eye. And the risk of failure is greater than trab.
Yeah.
So trab as compared to valve is, in my opinion, is better.
Yes.
And and a primary valve, as we had a discussion with Dr. Imran Masood during our fellowship, that he said that why this study was planned, that the primary valve we plant. He was adamant about this, that there is no question of implanting a valve in primary glaucoma surgery. It's only for certain indications.
Unless you have follow-up.
We have another interesting question.
There was an SMT question somewhere.
I'll come to that. And we're glad that it was a great interaction and it was very well received and enjoyed by the participants. And the question is from Dr. Zunaira Mubarak. In pediatric patients, we also do releasable sutures, and there's a question mark in that.
So I haven't operated on any pediatric patient in the last 30 years because in UK we don't touch pediatric. Pediatric glaucoma goes to pediatric glaucoma surgeon. So I don't know.
But the concept of this releasable suture in pediatric patient who you can't tackle on steadily difficult. But pediatric patient you need US termination anesthesia after a certain period. But if you have applied a good releasable suture with all the criteria, so maybe you can take care of it during anesthesia. But the better answer is, as Dr. Rashid has answered, that we don't have much experience in pediatric glaucoma surgery.
So most of the glaucoma techniques are based by Frank Cole, who's a pediatric glaucoma surgeon. I have no experience of operating or observing pediatric glaucoma management. So I'm sorry, I cannot answer this question for you.
And mobile show it on the screen if you can.
There was a question that SMT is better than trab.
Yeah, doctor, a very old buddy of Services Hospital. He's there. How much posterior dissection?
Okay, so for this you need to understand the anatomy of the subtenon space and the anatomy of subconjunctival space. I don't think I can explain in words that we have to make very complex diagrams.
Actually, I think this question has been answered.
Yeah.
Because when Dr. Burke asked this question, there were 3-4 slides which actually by video depicted how much dissection should be there, and then there was Imran Masood's video clip.
So on either side,
he was placing the sponges.
So
hopefully this.
So either side of the trabecular strip, when you're using a tenotomy scissors or your blunt dolphin face scissors, spring action. So they have a screw at the end of the prongs of the scissor. So what I use is that screw as a reference mark. That's how deep I go in. So I go very deep with that spring scissors up to the mark of the screw on the either side of the spear rectus. That's under the subtenon space. But when I'm dissecting over the spear rectus, then I'm very careful. I tend to dissect in the subconjunctival space rather than the subconjunctival space, because that otherwise it can cause bleeding, which is very difficult to stop. So on either side of the spear rectus, go very deep, but
almost fulfill the insertion of the superior rectus muscle. And now your old friend is there on the screen with a question. Of SMT.
Yes, SMT is better option than primary. I think this is a question. The relevance of this question is very big because this is just not a clinical question. This is also a question which we call as HTA, Health Treatment Assessment, and that's a very complex.
It's a question of an RCT.
RCT. But the thing is, SLT is nothing but rejuvenation of your trabecular meshwork and also sometimes post-trabecular meshwork corrected channels. But it can only attain a physiological, it can only attain a physiological pressure if it's successful. SLT, if you look at the light data, that is quite different from the data of the real world consortium by UK. So in real world, the SLT fails far more often than what was depicted in my trial. I use SLT in selected patients, even though the NICE guidance use SLT as a primary procedure, but I really do not, I deal with complex patients. If you're dealing with complex patients, then TRAB is the better option rather than doing SLT. Because once you've done SLT, you cause the inflammation, God knows when that inflammation is going to settle down. And SLT works by a mechanism called thermal relaxation. So it absorbs the energy, then that energy is released at a slow pace, causing the biological reactions in the surrounding tissues. And that biological and reaction takes about 4 to 6 weeks to work. When you're planning TRAB, you don't have 4 to 6 weeks. You want to do TRAB to save vision. You can't wait 4 to 6 weeks for the pressure to come down, which may not in the first instance, especially if the pressure was very high. Although people say that SLT works in patients who have higher pressures, but when you're planning TRAB, those are the patients where the trabecular meshwork has packed up. So if a trabecular meshwork has already packed up, you can't rejuvenate. These are the cases where you do any kind of intraocular procedure. The trabecular meshwork will decompensate. Decompensation of trabecular meshwork is a concept very similar to the decompensation of corneal endothelium after phaco surgery. If you have focus dystrophy, you do phaco, you can likely do decompensate endothelium. Similarly, a patient who has very advanced glaucoma, 0.9 CD ratio, is also likely to have a very poor, is very likely to have a very poor trabecular meshwork. And in such patients, if you do even YAG capsulotomy, that energy release can decompensate the trabecular meshwork cells, their function, leading to certain spike of pressure. That's why you gave iodine and TM patient after YAG capsulotomy, because the pressure can rise, the trabecular meshwork may stop working. And similarly, in such patients, if you do SLT, you can have intractable glaucoma. So if you look at the data, you'll find in 7 to 8% of SLT patients, the SLT doesn't work in primary SLT, which are not very advanced glaucomas. And in 1 to 2% of patients, you have intractable glaucoma. So a person where you are planning TRAB in the first place, SLT is not an option because you can just lead to intractable glaucoma.
Yes, because SLT is a kind of
SLT to 30 pressure, 5.6 CD ratio, 35.
very gentle procedure. But the real answer to kind of calcitrant glaucoma, which we are discussing, is TRAB or something bigger than SLT.
Yeah.
So I will just quickly go through now my presentation, which I skipped in favor of Dr. Rashid, and we will skip the slides which have already been discussed, and 1 or 2 clips I will stress, or we will just stress the point which is not discussed yet. So how to customize your trabeculectomy to make it more predictable and safer. So everyone is doing something about TRAB. Indications we have discussed: when your patient needs AZM or acetazolamide to control, then this is the time you really need to discuss the surgical intervention. And when you start the fourth drug, then you start considering the TRAB. And once the ACMOX is needed, absolute indication of surgical intervention is there. Incision surgeries are different, like penetrating, non-penetrating, we know, but I will not go in the details. We have already discussed that if you are not bypassing the whole outway, the drainage pathway, then it's a MIGS procedure. You are partially bypassing it, but not entering into the conjunctival space. If you enter into the conjunctival space, it's a penetrating surgery. And there are ablative procedures. We will come to that on some later. and then combined extraction, and it appears almost crime after listening to Rashid Zia and seeing the Rao Arif's remarks that it's an institutional blunder. So trabeculectomy is the king. In spite of all the refinements and innovations, yet the residents need to learn it. The young ophthalmologists should have it in their pocket, in their kind of tools, along with phaco. Trab should also be there, especially in countries like Pakistan. So the objective we have, and this is the, you see the Dr. Rashid mentioned and show you the picture of Peng Ha. And this is where this modern trabeculectomy got. This is a very classical diagram. It gives you many messages. Tight adjustable sutures, large treatment area, posteriorly directed flow, large scleral flap, not to cut to limbus. This is a very important point, that we had this concept of deep sclerotomy straddling the limbus in classical teaching of Trab, but it's no more being practiced by mentors of glaucoma around the world. They say that your sclerotomy, partial thickness scleral flap, should not alter the limbal anatomy or should not kind of invade the limbus. It should be away from the limbus a little. And deep sclerotomy should be, like Dr. Rashid very well explained, large scleral flap, not to cut to limbus, and single or dual scleral punch sclerotomy. What we have seen in Dr. Imran Masood and Dr. Rashid, that they use 0.5 millimeter Callis punch, one on the interior lip and the other pass on the posterior lip, and it gives you 1 millimeter wide sclerotomy. So this beautiful diagram tells you the whole story of Trab. That's why I have put it here. Making trabeculectomy safe and predictable, prepare the stage with wisdom's light, where steady hands must work aright. तो ये हमने कर लिया था, मेरा ख्याल है कि वो कहते हैं एप्लाक्लोनिडीन बंद कर दें ताकि आपका सर्जरी, ये डॉक्टर राशिद ज़िया की बड़ी खूबसूरत टिप है जिसमें आप एक कैनुला यूज करते हैं ताकि आपकी कंजक्टिवल डिसेक्शन आसान हो जाए. क्या नाम है इसका?
नाम तो नहीं,
नहीं है नाम, आपने बताया था. ये जो जिससे आप हाइड्रेट कर रहे हैं कंजक्टिवा को, हाँ, रायक्रॉफ्ट कैनुला. और ये हम उसका ट्रैक्शन सूचर लगा रहे हैं. इसमें वो बड़ी खूबसूरत बात की थी डॉक्टर फैसल ने कि हम 4 मिलीमीटर का बनाते हैं फ्लैप विड्थ उसकी, और उसकी जो पोस्टीरियर लिमिट है वो हम 2 मिलीमीटर रखते हैं ऑलमोस्ट. तो दिस इज अ ब्यूटी अबाउट ट्रैक्शन सूचर कि 2 millimeter away from the limbus and about 4 millimeter wide, so that it doesn't cheese wire. And the ideal suture is 7-0 vicryl with a spatulated needle. And Dr. Rashid has already shown it. This is conjunctival dissection. कैसे प्यार से हाथ लगा रहे हैं ना, फूलों की तरह. जितना कंजक्टिवा से मोहब्बत से पेश आएंगे उतना ही वो अच्छा बिहेव करेगा पोस्ट ऑपरेटिवली. और उसके जो सेफ्टी बने होते हैं, दैट शोज द इम्पोर्टेंस ऑफ डिसेक्शन एंड मेकिंग वेरी गुड पॉकेट्स. ये हैंडमेड शाहकार है डॉक्टर राशिद ज़िया का, जो आप देख रहे हैं स्क्रीन पे. ये सेफ्टी को शो कर रहे हैं कि जिनको ब्रेक करना जरूरी है फॉर प्रॉपर ब्लैब टू वर्क. अगर ये इनको आप प्रॉपरली डिसेक्ट नहीं करेंगे और टूकेज नाइफ से एपिसिक्लेरल फाइब्रोब्लास्ट को क्लीन नहीं करेंगे तो सिस्टिक ब्लैब बनने का खतरा है. एम राइट? और स्क्लेरल फ्लैप का डिजाइन 4x2 मार्क कर लें. जितने आप प्रीसाइज होंगे, जितनी अटेंशन टू द डिटेल देंगे, उतने आपके रिजल्ट्स ज्यादा प्रिडिक्टेबल और अच्छे होंगे. और शार्प और अच्छा क्रेसेंट नाइफ यूज करें, और लेटरल कटिंग जो है वो स्ट्रेट वर्टिकल नाइफ से करें ताकि उसके जो एज बने वो शार्पली अप्रॉक्सीमेट हो जाएं और लेटरल लीकेज का इम्कान बाकी ना रहे. अगर हम वहाँ एंगल नाइफ यूज करेंगे तो उनको फिर अप्रॉक्सीमेट करना 1-2 सूचर्स की मदद से मुश्किल होगा. और 4/2 मिलीमीटर है उसका डायमीटर, और आपने रिलीजेबल सूचर्स लगाने हैं. एक्स्ट्रा सूचर भी लगा सकते हैं. ये सारे पॉइंट्स स्ट्रेस हो गए हैं. और पेरिफेरल आयोडेक्टमी करनी है बड़ी मोहब्बत से, enough but not too big. और हमें टिश्यू की रिस्पेक्ट करनी है, हमें बहुत केयर करनी है, लेकिन किसी भी पॉइंट पे ओवरडू नहीं करना. हमने ट्रामा नहीं देना आई को. जितना ट्रामा कर देंगे, जितना ओवरडू करेंगे, उतना आई रिएक्ट करेगी, उतना आई का टिश्यू रिएक्ट करेगा. और रिएक्शन जो हमने इनवाइट कर लिया अपनी एक्सेसिव हैंडलिंग से, दैट्स अ रीजन ऑफ बिग फेलियर. पोस्ट ऑपरेटिव मैनेजमेंट में काफी चीजें डॉक्टर साहब ने बता दी. और स्टीरॉयड उन्होंने कहा जी है, मैं वैसे थे यही लिखा है 3 to 24 months, तो वो अब वहां मैनिंग कर देंगे. हाँ प्लीज.
So, अगर आप, if you look at the practices of post-op steroids in UK, so UK को you can broadly divide into south of the UK and north UK. North में people they tend to use Predforte, whereas in south they use preservative-free dexamethasone because in Moorfield they say that they do not want the toxic effects of preservatives. Whereas in North, they say that in initial phases of post-op trab, you want to dampen inflammation that may come even at the cost of ocular surface inflammation, causing preservative toxicity.
Yes.
So what I was doing was using preservative-free dexamethasone previously, but now I've moved to using Predforte for the first 2 months, and then I have moved to preservative-free dexamethasone. But in many cases, I think if you do not have preservative-free dexamethasone, then stick with Predforte, not dexamethasone. Predforte has far higher concentration of aqueous penetration, and glaucomas are not the same. If you have two glaucomas, open-angle glaucomas with 30 pressure, both of them may be genetically different, which means that the aqueous composition is different. They may have different leukotrienes, different TGF-beta concentrations, different prostaglandins and aqueous. So one of them may need post-op drops for 3 months, other may need post-op drops for 2 years. You just do not know. So always assess each post-op trab patient according to the vascularity of the bleb. And don't say that I'm going to reduce the tail of steroids in 2-3 months. That's wrong.
That point has been really stressed in today's presentation.
Give steroids for as long as needed. I give 2 hourly steroids first 2 months. Then if the vascularity is settling down and start reducing, and sometimes in majority of cases 6 to 7 months I'm off, but in many cases it's ongoing for even 2 years.
तो ये समरी ऑफ की प्रिंसिपल्स वो पेंखा की डायग्राम है, वो आपको इंशाल्लाह रिव्यू के लिए अवेलेबल होगी. और हाइपोटनी को हर सूरत आपने रोकना है. वो आपने प्रेजेंटेशन में भी देख लिया कि हमारा सबसे बड़ा दुश्मन इंट्राऑपरेटिव एंड पोस्ट ऑपरेटिव हाइपोटनी है. जो हाई प्रेशर है उसको मेंटेन कर सकते हैं, मैनेज कर सकते हैं, रिलीवेबल सूचर कर लेंगे, कोई नीडल रिवीजन कर देंगे. लेकिन हाइपोटनी जो कॉम्प्लिकेशंस मैकुलर एडीमा और व्यूअर लॉस और कोराइडल्स की सूरत में और रेटिनल रिंकलिंग की सूरत में कर देगी, और जो एसी को डिस्टार्ट कर देगी और जो सैनिकी बना देगी, दैट्स अ काइंड ऑफ नाइटमेयर. इसको हमने हर सूरत में इससे बचना है. सारी की सारी जो मॉडर्न ट्रैप का जो आज का थीम है, जो उसका जो सारा रिवॉल्व करती है, वो ये है कि आपने फिस्टुला तो बनाना है लेकिन हाइपोटनी नहीं होने देनी. तो ब्लैब फेलियर में भी यही सबसे बड़ी चीज है. ये फिर किसी वक्त का टॉपिक है कि हम उसकी कॉम्प्लिकेशंस को.
Is a question के post-op, what should be the post-op IOP in first post-op day in adults or pediatrics? So what we aim for is you are experienced enough that on the first post-op day you have pressure around 10. But when you start doing releasable sutures, you post-op, because you'll be going towards tighter sutures, your post-op pressure on the first day may be in 20s. So that's absolutely fine. It's easy to come from 20 to 10, but not possible to go from 2 to 10. So if without doing anything, your pressure is anything up to about 12, 13, 14 pressures, don't do anything. Okay, see the patient again in 5 to 7 days. If it's still the same amount of pressure under 12, 14, don't do anything. Then the most important phase is the 2 weeks. At 2 weeks, you can start thinking of releasing the suture. Release the first suture. Ask the patient to sit down for 10 minutes or so, recheck the pressure. If pressure has come down automatically to 10 or less, wonderful. If it's still about 14, 15, not coming down, then do massage again. Massage is a good friend, and that will bring the pressure down definitely. Very rarely, you will find that you have to release both sutures because patient is healing very aggressively. But even if you have to do that, do not do it on the first day.
And do it in staged manner.
Yeah.
Maybe on the second week you do one,
Curtail
and give
your-
another week for the other one.
Curtail your drive to remove suture if pressure is going high and it's not coming down. It may still be needed. I have removed sutures very early, maybe as early as 3 or 4 days sometimes. But if I've done it 10 times to remove early sutures, in 8 of them times I ended up having hypotony. So it's best to just wait at least, maybe in a heavy prophylactic healer, wait at least a week. Otherwise, 2 weeks is a good standard. But you have to make sense decisions yourself. Time is just a very broad thing. Every individual heals differently. So do not use 1 week pe hi karna hai, 2 weeks pe hi karna hai. That's wrong. Make your own generic, customized decisions, not generic decisions.
I would add a little point here that, for example, you are dealing with end-stage glaucoma, and the first post-op pressure is 20 or 25. Now your concerns are a little different. You are not going to release the suture, but you don't want this pressure in an end-stage glaucoma patient where there may be some only 10 degrees field left. So we want his pressure down, but use other measures like massage, like adding Esimox, like adding some drops for a while. The other thing which Dr. Rashid and Imran Masood have stressed, I will add to his saying that 2 weeks is the time. But there is another very important consideration in the period of 2 weeks. That is, in 2 weeks' time, you have to have a fistula.
Yes.
If there is no fistula and scared of hypotony, you did not time release of your sutures in 2 weeks plus minus time, then your trab is failed. Because after that, if the fistula is not established, it will be very difficult to establish the fistula. So this is what Dr. Rashid means by time, because the decisions are tailored to the need of the patient, to your clinical acumen and particular decision. There is no kind of perfect time and space which you can be given, you do this, you do this. Every patient needs a little different management. And this is a beautiful graphic from American Academy of Ophthalmology to show traction suture, 2 millimeter from the limbus. And handle the conjunctiva gently. और कितना को होना चाहिए पेरिटमी का साइज? क्या आपने 4 मिलीमीटर बनाना है ना स्क्लेरल फ्लैप, तो 2 मिलीमीटर दोनों तरफ ऐड कर लें. मे बी 7 to 8 millimeters इज इनफ. और बड़ी प्यारी सी करें, उसको लेटरल कट्स देने की जरूरत नहीं है. जितना ज्यादा कट दे देंगे, जितना उसको रिलैक्स कर देंगे, उतने ज्यादा सुचर लेंगे, उतना ज्यादा ब्लीडिंग होगी. और ब्लीडिंग इज आवर एनिमी. एप्राक्लोनिडीन यूज करें, बड़ी प्यारी सी लिम्बस पे हल्की सी काटरी करें, लेकिन डोंट लेट योर ब्लड ट्रेवल इनटू द स्पेस वेयर यू आर गोइंग टू अप्लाई माइटोमाइसिन सी. क्योंकि फाइब्रोब्लास्ट ये तो हमारे दुश्मन है. तो ब्लड अगर आ गया तो ब्लड तो हम इंजेक्ट करते हैं ब्लड को स्पीड कम करने के लिए, तो इसलिए हमने ब्लडलेस फील्ड चाहिए हमें. और डिसेक्शन वही है, वो आपने दोनों तरफ करनी है. ये ग्राफिक्स बड़ी प्यारी थी इसलिए मैंने क्लिप की हुई है. और साइज उसका बड़ा खूबसूरत रखना है. काटरी ना तो चारिंग करनी है और ना ही, वो तो आपने देख ही लिया था. ये कोई हमारी बड़ी क्लासिकल ट्रैब है गए वक्तों की, अबाउट 5, 6, 7 years old, जिसमें उसी तरह मोहब्बत और एहतियात से जैसे डॉक्टर राशिद कर रहे थे, मैं कंजक्टिवा को देखे कितने एहतराम से अप्रोच कर रहा हूँ. तो ये जो एहतियात है, ये जो मोहब्बत है, ये आपको ट्रैप को सक्सेसफुल बना के देगी कि आप उसको बहुत हल्का सा आपने किया है और फिर उसने आपने उसको ब्लंटली डिसेक्ट कर लिया है, फिर थोड़ा सा उधर कर लिया है. और वो जो फोर्सेप्स हैं आइडियल हॉस्किन्स और वो ख़ास किस्म के जो प्लेटफॉर्म्स हैं वो तो हमारे पास नहीं होते, लेकिन अगर आपके पास कॉर्नियल फोर्सेप्स ही है तो यूज़ इट वाइजली एंड जेंटली। और जो ही आपको थोड़ा सा मिल जाए कांच, तो फिर आप उसको अंदर वाली सिम से 3 आर्म से होल्ड कर लें, ताकि आपका बटन होल ना बने। बटन होल हमारा दुश्मन है। और पेरिटमी का साइज देखें, एनफ है कि आपका एक फ्लैप बन जाए बस। और एमएमसी के लिए आपने पीछे जगह बनानी है, और फॉर्निक्स बेस्ड फ्लैप ही बेहतर है, वो देख लिया, तकरीबन सारे ही सर्जन उस पर एग्रीड हैं, तो मैं स्किप करता जाऊंगा। और ये टेक्निक है सोक्ड स्पंजेस वाली, और काटरी जो है बहुत जेंटल, यहाँ पे वो भुना हुआ जो है ना वो रोस्टेड सक्लेरा एपिसक्लेरा नजर नहीं आना चाहिए, जस्ट एनफ वाइट और उसकी कार्टराइजेशन हो और फील्ड आपका साफ हो जाए। और काटरी करते हुए भी आपने कांच को बचाना है दोनों तरफ, लिम्बल साइड पे भी, और आपने जो पेरिटमी की हुई है उसका मार्जिन भी कार्टराइज ना हो जाए। और ड्राई क्लीन फील्ड मिल गया आपको, तो अब आप अगले स्टेप पे। दूसरा तरीका ये है जिसके ऊपर भी हमारे मेंटोर्स तो ज्यादा कन्विंस नहीं है, लेकिन इंटरनेशनली इस पे काफी काम हो रहा है और मैं यूज करता हूँ। मैंने इसमें स्पंज लगाने की बजाय यहाँ पे उसको पोस्टीरियरली माइटोमाइसिन सी को इंजेक्ट कर दिया हुआ है। उसके लिए 0.02% की कंसंट्रेशन यूज करते हैं जस्ट बिफोर स्टार्ट ऑफ द सर्जरी। और उसमें हमने जो लर्न किया ओवर टाइम कि उसको आप इंटीरियरली लिम्बस के पास इंजेक्ट ना करें, उसी स्पेस में करें जहां आप माइटोमाइसिन रखते हैं, और जहां आप पोस्टीरियरली डायरेक्टेड फ्लो चाहते हैं वहां इंजेक्ट करें। तो ये आपने एक स्टडी शो की थी डॉक्टर राशिद ने, कि जिसमें आपने बताया था कि कम से कम इन दोनों का जो सेफ्टी प्रोफाइल है और जो आउटकम्स हैं वो इक्वल हैं, अगरचे अभी कोई प्रॉपर कंपैरेटिव स्टडी नहीं हुई। बट दिस इज एन ऑप्शन which saves time as well as the risk of touching of the conjunctival margins during the application of sponges. And there is a rare complication of sponge application that you may leave some sponge in subconjunctival space, like the general surgeons leave those pads in the abdomen. So Dr. Rashid uses stained sponges to avoid this problem. हल्का सा मार्कर टच किया होता है तो वो फिर नुमाया रहता है, उसको आप निकाल लेते हैं। बाकी जो आप कैलिस पंच आपने देख लिया, ये हमारा पुराना हथियार है। और वो एक डिस्कशन हमारी हो रही थी ट्रैप पे, तो मैंने डॉक्टर इमरान मसूद को कहा कि आई हैव दिस इंस्ट्रूमेंट ऑफ लास्ट सेंचुरी टू टेक केयर ऑफ माय विंडो। तो आप कर सकते हैं मजबूरन इसके साथ भी। मेरे पास 1 मिलीमीटर का पंच तो है, but I'm going to do my next trap with 0.5 millimeter punch इंशाल्लाह। तो वो उस करने से आपका ये ट्रामा सारा बच जाएगा। आपने सिंपल कैराटोम से एंट्री ली इंटीरियर चैम्बर में, एक एंटीरियर लिप से काटा, एक पोस्टीरियर लिप से काटा, एंड यू आर देयर। फ्लैप डायमेंशंस का आपने ख्याल रखना है। फिर वो ग्राफिक है 1/2 to 1/3 थिकनेस, अच्छा फ्लैप होना चाहिए जो कि आप सूचर्स वगैरह को होल्ड करे। अगर आपकी हाफ थिकनेस से कम होगा तो वो आमतौर पर फिर कई दफा बटन होल बन जाता है, उसमें वो गिव वे कर जाता है। तो थिक अच्छा स्क्लेरल फ्लैप होना चाहिए, बट नॉट टू डीप कि आप शुरू में खोल के बैठे हो सिलरी बॉडी को। तो रिलीजिंग सूचर्स, ये तो आपको बहुत अच्छी तरह डॉक्टर साहब ने 2 वीडियोस की मदद से एक्सप्लेन कर दिया। तो ये हमारे वाली टेक्निक है जिसमें आपने उसको दोनों तरफ से काटा है 11-0 या 15 डिग्री ब्लेड से, और सीजर से काट रहे हैं। उसके बाद आपने प्यारी सी एराडेक्टमी करनी है। और यहाँ पे एक चीज है जिसकी कैलिस पंच आ गया तो शायद जरूरत कम हो। यहाँ वो काम है जो किया हुआ मैंने, जो नहीं करना चाहिए, क्योंकि मैंने लिम्बल एनाटमी को क्लासिकल टीचिंग की बुनियाद पर टच किया हुआ है। हमने स्क्लेरल फ्लैप को लिम्बस तक आइंदा नहीं लेके जाना। तो यहाँ पे मैं ना एक स्क्लेरल फ्लैप को असिस्टेंट की हैंडलिंग से जवाद को पकड़ाने की बजाय कि हंस के कहे कि सर जी ऐसे उतर ही गया जी, मैंने वो उसको हल्का सा स्टिच लगा के स्क्लेरल फ्लैप को तो अपोजिट लिम्बस पे रिट्रैक्ट कर लिया। दिस गिव्स यू एक्सीलेंट एक्सपोजर। तो ये हमने एक थाईलैंड में हुई थी हमारी ऑप्थेल्मिक अपडेट, तो उसमें मैंने मजरीज रिट्रैक्शन सूचर इसका नाम रखा था। तो हाँ, तो ये मतलब इंटरेस्टिंग है। ये सिर्फ अभी तक कहीं रिपोर्ट नहीं है, ना ही मैंने किसी को रिपोर्ट किया, लेकिन वन ऑफ द एमिनेंट ग्लाकोमा सर्जन बैठे हैं, तो मैंने उनके सामने जुर्रत की है दिखाने की कि ये हमें असिस्टेंट फ्री हैंडलिंग का मौका देती है कि इवन आपने कैलीज पंच भी लगाना है तो अब आपको उसको पकड़ने की भी जरूरत नहीं है, आपको बड़ा पार्शियल थिकनेस हल्का सा सूचर लगाना है, और जो ही आपकी ये डीप स्क्लेरोटमी कंप्लीट होगी तो बड़ी आसानी से ना आपने यहीं पे देखें, वो फौरन ही मैं उसको आयराडेक्टमी करते ही मैंने उसको ये आयराडेक्टमी की और साथ ही उसी सीजर से मैंने उसको काटा और दैट्स इट, ये फ्लैप वापस आ गया। तो इट एड्स अ लॉट ऑफ गुड एक्सपोजर एंड स्मूथनेस टू द प्रोसीजर। कैसे खाएं, डॉक्टर राशिद करवा देंगे, इन्होंने कह दिया तो पेटेंट हो गया, तो तारीफ कर दी ना उन्होंने। अच्छा जी, तो स्क्लेरल फ्लैप अप्रोक्सीमेशन डॉक्टर राशिद साहब ने आपको बता दी है, वो हेल्दी बाइट्स होनी चाहिए, अच्छा 4 थ्रोज लेके करना है, ये विंग सूचर्स का कॉन्सेप्ट है, और फिर सेंटर में हमने ओवरलैपिंग सूचर्स लगा देने हैं। तो सर्जिकल कॉम्प्लिकेशन ये देखें, यहाँ इंटरेस्टिंग चीज़ है, ये डॉक्टर मसूद साहब से मैंने क्लिप की हुई है, इमरान मसूद से, कि यहाँ ना एक सल्कस सा बन रहा है कंजक्टिवा में, उसको इतना टाइट लगाना है कि वहां एक ऐसे डिप्रेशन सा पैदा हो जाए, तो दैट विल शो कि आपका कंजक्टिवा वेल अप्रोक्सीमेटेड है और लीक नहीं होगी। हाइपोटनिक से आपने बचना है, और बाद में नीडलिंग वगैरह कर सकते हैं, वो जब हम कभी करेंगे कॉम्प्लिकेशंस तो फिर उसको डील कर लेंगे। टच द आई एज अ लवर्स ग्रेस with tender art and soft embrace. With passion, practice, knowledge, and skill, make your trab safe by God's will. So, with this, we end up our webinar. It's already beyond 11 o'clock.
Thank you very much, sir.
So, thank you, Dr. Rashid, for sparing a couple of hours for us,
No problem.
for residents, and for benefit of ophthalmic community. And we are glad that our community joined actively, and we had very good questions from the participants, and some seniors were also there, like Rifat Burke and like Rao Arif. So it was a wonderful and a memorable session, and at the same time I need to thank BPOS British Pakistan Ophthalmic Society and Virtual Ophthalmology Academy with the news that inshallah these recordings properly edited will be available on VOPHA YouTube channel, and we will share the link with the participants as well as with Dr. Rashid. And at the same time, I need to thank Malik Noman, our manager and assistant. His passion and contribution made this webinar a success. Allah has blessed him with skill and a concentration, and only he knows and a little I know how this overnight 2 HDMI cables were arranged, one for straight lamp and one for the laptop. And Alhamdulillah, we thank Almighty Allah that at short notice, me and Dr. Rashid planned this webinar, and we are able to exercise it properly. And inshallah, it will pave the way for future endeavors, and we will be benefiting from your skill and knowledge from UK as well. As we had Dr. Ijaz Sheikh today with us, we will make it a feature once every month or every 2 months. We can have these activities, inshallah. So thank you again. कोई और question तो नहीं आया हुआ? So with this we end. Thank you everybody, and thank you my residents, and thank you Dr. Jawad for arranging the bouquet. And now we will have a group photo. And with this we end and say goodbye and Allah Hafiz to our participants from national and international ophthalmic community. Thank you all.